Bismillahirrahmanirrahim. Details of descriptive study in epidemiology. Descriptive epidemiology is the study of the amount and distribution of disease or health status within a population. By person, place and time, it usually involves the determination of incidence, prevalence and mortality rates for disease in large population groups according to characteristics such as sex, age, race and geographical area. For these studies, data on causes and effects in an individual are often not known. It is the study of factors responsible for distributions of health and the disease in human population such as age, sex, social status, income, occupation, housing, social customs, habits. It provides the body of knowledge for the epidemiological study. Descriptive epidemiology also studies other factors such as time distribution when it gives the duration of epidemic and periodicity of the disease. Time distribution The descriptive study is the best study in the human mankind. This statement emphasizes the importance of making the best use of observation on individuals or population exposed to suspect factors of disease. Meticulous observation made in Africa led to eventual incrimination of Epstein-Barr virus as the etiological factor by other factors such as malarial infection of the type of cancer known as Burkitt's. It was the epidemiological study in New Guinea, a hereditary neurological disorders that led to discovery of slow virus infection as the cause of chronic degeneration, neurological disorders in human beings. Descriptive studies are usually the first phase of an epidemiological investigation. These studies are concerned with observing the distribution of disease or health-related characteristics in human population and identifying the characteristics with such the disease in question seems to be associated, which studies basically ask the question: when the disease occurring, it's a time distribution, where is it occurring, it's a place distribution, who is getting the disease, it's a person distribution. The various procedures involved in descriptive study may be outlined. Number 1, defining the population to be studied. Number 2, defining this disease under study. Number 3, describing the disease of time, place and person. Measurement of diseases, comparing with known indices, and sixth, formulation of etiological hypothesis. Number 1, defining the populations. Defining the population. Descriptive studies are investigations of population, not individuals. The first step is therefore to define the population base not only in terms of the total number but also its composition in terms of age, sex, occupation, cultural characters and similar information needed for the study. The defined population can be the whole population in a geographic area or more often a representative sample taken from it. The defined population can also be specially selected groups such as age and sex group, occupational group, hospital patient, school children, small communities as well as wider groupings. In fact, wherever a group of people can be fairly accurately counted, The defined population needs to be large enough so that age, sex and other specific rates are meaningful. The community chosen should be stable without migration into or out of the area. It should be clear who does and who doesn't belong to the population. For example, visitors and relations, perhaps the most essential ingredients in community participation, which must be forthcoming. Furthermore, the population should not be oddly different from other communities in the region. Finally, our health facilities should be close enough to provide relatively easy access for patients requiring medical services. In the famous Fringman-Hurd study in US, all the above criteria were taken into consideration in choosing the study of population. The concept of defined population or population at risk is crucial in epidemiological studies. It provides the denominator for calculating rates, which are essential to measure the frequency of disease and study its distribution and determinants. Epidemiologists therefore have been labeled as men in search of a denominator. Number 2, defining the disease under this study. Once the population to be studied is defined or specified, one must then define the disease or condition being investigated. Here the needs of the clinical and epidemiologist may diverge. The clinicians may not need a precise definition of disease for immediate patient care. If the diagnosis is wrong, he can reverse it subsequently. But the epidemiologist, whose main concern is to obtain an accurate estimate of disease in a population, needs a definition that is both precise and valid to enable him or observers working in the field condition to identify those who have disease from those who don't have. The diagnostic method for use in epidemiological studies must be acceptable to the population to be studied and applicable to their use in large population. In other words, the epidemiologist looks out from an operational definition, that is, definition by which the disease or condition can be identified and measured in the defined population with the degree of accuracy. For example, tonsillitis. Third, describing the disease. The primary objectives of descriptive epidemiology is to describe the occurrence and distributions of disease or health-related events or characteristics within population by time, place, and person, and identifying those characteristics associated with presence or absence of disease in individual. These are 5 W's: who, what, why, when, where, and so what. This involves systematic collection and analysis of data. Some of the characteristics most frequently examined by epidemiologists in descriptive studies. It's only an initial separation or grouping of variables according to time, place, and persons, and not a classification of casual factors. Characteristics frequently examined in descriptive studies are time, place, and person. Time, year or season. Place, climatic zones. Person will be divided into age and birth order. Month or week. Country, place, country or region. Sex. Person, family size. Time, day, hour or onset. Place, urban or rural, local communities. Person, marital status, height and weight. Duration. It will be included in time. Place will be towns, cities, institutions, while persons will be occupations, social status, their education level, and their blood pressure, their blood cholesterols, and personal habits. Occurrence by week, month, the day of the week, hour of onset, etc. It raises questions. According to the modern concepts of epidemics is defined, the occurrence in a community or a region of cases of an illness or other health-related events clearly in excess of normal expectancy. The community or region and the time period in which the case occurs are specified precisely. Epidemiology is thus relative to usual frequency of the diseases in the same area among the specified population at the same season of the year. These are the types of studies. Types of studies, their alternative names and units of study. Observational study, descriptive study, analytical study, ecological, correlational, this is the alternative name, and unit of study is the population. Cross-sectional, alternative name, prevalence, unit of study is the individual. Case control study, case, alternative name, case reference, and unit of study is individuals. Cohort is the study, types of study, alternative name, follow-up, and unit of study is the individuals. Experimental studies or interventional studies. Randomized controlled trial, alternative name, clinical trial, unit of study, patients. Field trials, healthy people, unit of study is the healthy people. Community trial, alternative name, community studies, and the unit of study is the communities. Defined population should be large enough, stable, non-migrant people, clear on who belongs to the population, and community participation. Defining disease under the study. Seasonal calendar. Why is it? This is the question which is arised. So why it's important? Epidemiologists need a definition that is precise and valid to obtain an accurate estimation about the disease. A definition by which the disease or condition can be identified and measured in the defined population with a degree of accuracy. For this purpose, we have already discussed this. Defining the disease, we have mainly operational definition, the disease keeping in the mind the objective of study. Describing the disease, its main thing is the time distribution, short-term fluctuation, periodic fluctuation, and long-term fluctuation. Short-term fluctuation, common source epidemic, single exposure or point source, continuous or multiple source, periodic, seasonal trend or cyclic trend, long-term fluctuation, secular trend. Short-term fluctuation, A, common source epidemic. Number 2, propagate epidemic, person to person, orthopod to vector, animal reservoirs, and C, slow or modern epidemic. Epidemiologists have identified three kinds of time trends of fluctuation in disease occurrence, short-term fluctuation, periodic fluctuation, and long-term fluctuation. Short-term fluctuation. The best known short-term fluctuation in the occurrence of disease is an epidemic. According to modern concept, an epidemic is defined as the occurrence in a community or region of cases of an illness or other health-related events clearly in excess of normal expectancy. The community or region and the time period in which the case occur are specified precisely. Epidemiology is thus relative to usually frequency of the disease in the same area among the specified population at the same season of the year. Types of epidemic. A. Common source epidemic, single exposure or point source of epidemic. Continuous or multiple exposure epidemics. Number 2. Propagate epidemics. Person to person, arthropod vector, animal reservoirs. C. Slow modern epidemics. A graph of the time distributions of epidemic cases is called the epidemic curve. The epidemic curve suggests a time relationship with exposure to suspected source. Number 2. A cyclical or seasonal pattern suggested of a particular infection and common source or propagated spread of the disease. A. A common source epidemic. A common source single exposure epidemic. These are also known as point source epidemics. The exposure to the disease agent is briefly and essentially simultaneously. The result cases will develop within the incubation period of the disease. A common source of single exposures epidemic. The curve has usually one peak, open point of interest in the median incubation of period. It's the time required for 50% of the cases to occur following exposures. The main features of the point source epidemics are: number 1, the epidemic curve rises and falls rapidly with no secondary waves. Number 2, the epidemic trends to be explosive. There is clustering of cases within a narrow interval of time. Number 3, more importantly, all the cases develop within one incubation period of diseases. Common source epidemics are frequently but not always due to exposure to an infectious agent. They can result from contamination of the environment, air, water, food, and soil by industrial chemicals or pollutants. B. Common source, continuous or repeated exposure. Sometimes the exposure from the same source may be prolonged, continuous, repeated, not necessarily at the same time or place. B. Propagated epidemics. Seasonal trend. Propagated epidemics. A propagated epidemics is most often of infectious origin and results from person to person transmissions. This is propagated epidemic. Infectious agent epidemics of hepatitis A and polio. The epidemic usually shows a gradual rise and tails off over a much longer period of time. Transmissions continues until the number of susceptibles is depleted or susceptible individuals are no longer exposed to infected persons. The speed of spread depends upon herd immunity, opportunities for contact, and secondary attack rate. Propagated epidemics are more likely to occur where large number of susceptibles are aggregated or where there is a regular supply of new susceptible individuals, that is birth and immigrants, lowering herd immunity. Periodic fluctuation. Periodic fluctuation is basically seasonal trend and cyclic trend. Seasonal trend. Seasonal variation is a well-known characteristic of many communicable diseases. For example, measles, upper respiratory infections, malaria. Measles is usually at its highest in early spring, and in upper respiratory infections frequently show seasonal rise during winter months. Bacterial gastrointestinal infections are prominent in summer months because of warm weather and rapid multiplications of flies. The seasonal variations of disease occurrence may be related to environmental conditions, for example, temperature, humidity, rainfall, overcrowding, life cycle of vectors, etc., which directly or indirectly favor disease transmission. However, in many infectious diseases, for example polio, the base of seasonal variation is unknown. Non-infectious diseases and conditions may sometimes exhibit seasonal variation, for example sunstroke, snake bites. Some epidemiologists would regard seasonal trend as form of cyclic trend. A typical pattern of seasonal trend, the outbreak of dengue starting by month of July and peaking in September, October and November, coinciding with the late summer and rain. Cyclic trend. Some diseases occur in cycles spread over short periods of time, which may be days, weeks, months or years. For example, measles in the pre-vaccination era appeared in cycles with major peaks every 2-3 years and rubella every 6-9 years. This was due to naturally occurring variations in herd immunity. A buildup of susceptibles is again required in the herd before there can be another attack. Influenza pandemics are known to occur in intervals of 7 to 10 years due to antigenic variations. Non-infectious conditions may also show periodic fluctuations. For example, automobile accidents in the US are more frequent on weekends, especially Saturdays. A knowledge of cyclists of diseases is usually in that it may enable communities to define themselves. Number 3, this one is the long-term fluctuation, secular trend. The term secular trend implies changes in the occurrence of disease, that is progressive increase or decrease, for a very long period of time, generally several years or decades. Although it may have short-term fluctuation imposed on it, a secular trend implies a consistent tendency to change in a particular direction or a definite movement in one direction. Examples include coronary heart disease, lung cancer and diabetes, which have shown a consistent upward trend in the developed countries during the past 50 years or so, followed by decline of such disease as tuberculosis, typhoid, diphtheria and polio. Interpretation of time trends. By surveillance or monitoring of time trends, the epidemiologist seeks which diseases are increasing, which decreasing, and which are the emerging health problems, and of the effectiveness of measures to control old ones. He tries to formulate etiological hypotheses and seeks explanation whether these changes were due to change in the etiological agent or variation in diagnosis, reporting, case fatality, or changes in age distribution or some other determinants, specific and non-specific. For example, changes in quality of life, socioeconomic status, and personal habits. For example, the time clustering of case even changes taking place over several years or decades can be productive of hypothesis. As in the case of lung cancer, by studying time trends, the epidemiologists seek to provide guidelines to the health administrator in matters of prevention or control of diseases. This is the time distribution. Disease can be described by time or its occurrence, week, month, year, seasonal, in occurrence, periodic decrease or increase, gives source of etiological and preventive measures, and three types of trends: short-term, periodic fluctuation, and long-term fluctuation. We have already discussed this short-term fluctuation. Periodic fluctuation we have also discussed, and long-term or secular trends we have also discussed. Place distribution. This is our next slide. Geographical comparisons. Number 1, differences in disease pattern between countries and within a countries. Number 2, importance of genes versus environment, changes with migration, and role of diet. Cultures and standard of living and external environment vary in different parts of the world. Study of the geography of disease or geographical pathology is one of the important dimensions of the descriptive epidemiology. By studying the distributions of disease in different populations, we gain perspective of the fascinating differences or variations in disease pattern, not only between countries but also within countries. The relative importance of genes versus environment, changes with migration, and the possible roles of diet and other etiological factors. In short, geographical studies have profoundly influenced our understanding of disease, its nature, its determinants, and its relations to subsequent pathology. The geographical variation in disease occurrence has been one of the stimulants to national and international studies. The world is not a uniform unit. Cultures, standards of living, and external environments vary greatly. The use of migrants studies is one way of distinguish genetic and environmental factors. The study of the geography of disease has developed its own special techniques, which sometimes involve complex statistical analysis. Geographic patterns provide an important source of clues about the causes of the disease. The range of geographic studies include those concerned with local variations at a broader level, international comparisons by examining mortality and morbidity in relation to socio-economic factors, dietary differences, and the differences in cultural and behavior. These variations may be classified: international variations, national variations, rural-urban differences, and local distributions. International variations. Descriptive studies by place have shown that the pattern of disease is not the same everywhere. For example, we know that cancer exists all over the world. There is, however, a marked difference between the incidence of each cancer in different parts of the world. Thus, cancer of the stomach is very common in Japan but unusual in US. Cancers of the oral cavity and uterine cervix are exceedingly common in Pakistan as compared to industrialized country. An international study of breast cancer showed that rate differs widely from country to country, with the lowest prevalence in Japan and the highest in the Western countries. Similarly, there are marked international differences in the occurrence of cardiovascular diseases. These variations have stimulated epidemiologists to search for cause-effect relationship between the environmental factors and disease. The aim is to identify factors which are crucial in the causes and preventions of disease. B. We have a national variation. National variation, it's obvious that a variation in disease occurrence must also exist within countries or national boundaries. For example, the distributions of endemic goiter, leprosy, malaria, nutritional deficiency disease have all shown variations in their distributions in Pakistan, with some parts of the country more affected and other less affected or not affected at all. Such a situation exists in every country. One of the functions of descriptive epidemiology is to provide data regarding the type of disease, problems and their magnitude in terms of incidence, prevalence and mortality rates. Such information is needed to demarcate the affected areas and for providing appropriate healthcare services. Third, we have rural-urban differences. Rural-urban variation in disease distribution are well known. Chronic bronchitis, accidents, lung cancer, cardiovascular disease, mental illness and drug dependence are usually more frequent in urban rather than rural areas. On the other hand, skin and zoonotic diseases, zoonotic mean animal diseases, and soil transmitted may be more frequent in rural areas than in urban areas. Death rates, especially infant and maternal mortality rates, are higher for rural than urban areas. These variations may be due to differences in population density, social class, deficiencies in medical care, level of sanitation, education, and environmental factors. The epidemiologist seeks to define groups which are at the higher risk for particular diseases and provide guidelines to the health administrators for their preventions and control. Local distributions. Inner and outer city variation in disease frequently are well known. These variations are best studied with the aid of spot maps or shaded map. These maps show at a glance areas of high or low frequency, the boundaries and pattern of disease distribution. For example, if the map shows clustering of cases, it may suggest a common source of infections or a common risk factors shared by all the cases. It was a study John Snow of England in his classic investigations of cholera epidemic in 1854 in the Golden Square districts of London was able to focus attention to the common water pump in Broad Street as the source of infection. Based on his descriptive findings, Snow was able to hypothesize that cholera was waterborne disease long before the birth of bacteriology. It was by a spot map by place of employment. The epidemiology is interested in a geographic variation in disease occurrence. Geographic distribution may provide evidence of the source of disease and its mode of spread. By relating these variations to agent, host, and environmental factors, he tries to derive clues to the source of disease and its modes of spread and formulate and test etiological hypotheses. The clinician is also benefited from knowledge that a patient comes to him from a certain geographic area which is endemic for certain frequent diseases such as leishmaniasis, as it helps him to focus attention on these diseases to which the patient may have been exposed. The geographic distribution of disease may change if change occur in the agent, host and environmental factors. The empires of malaria, plague and many other diseases have shrunk due to change in the epidemiological trait. On the other hand, cholera has shown an increasing geographic distribution due to changes in the disease agent. Since a mode of living and environmental factors vary from country to country, one would expect to find difference in the geographic distributions and frequencies of disease. Person distribution. Study of persons who develop disease based on host factors. These factors include age, sex, biomodality. Age. In descriptive studies, The disease is further characterized by defining the person who developed the disease by age, sex, occupation, marital status, habits, social class, and other host factors. These factors do not necessarily represent etiological factors, but they contribute a good deal to our understanding of the natural history of disease. Age. Age is strongly related to disease than any other single host factor. Certain diseases are more frequent in certain age groups within others. Measles in childhood, cancer in middle age, and osteoporosis in old age. If the attack rate of a communicable disease is uniform in all the age group, it implies that all age groups are equally susceptible and there was no previous immunity. Many chronic and degenerative diseases show a progressive increase in prevalence with advancing age. This may reflect a persistent and cumulative exposure to a causal agent or a risk factor. Bimodality. Sometimes there may be two separate peaks instead of one in the age incidence curve of a disease, as in case of leukemia and female breast cancer. This phenomena is known as bimodality age incidence curve. The curve is bimodal with an initial peak between age 15 and 35 years and later peak starting at age 50. However, there are 2 points relating to bimodality which make the interpretation difficult. A. Small number of observations are frequent source of bimodality. B. The absence of bimodality does not signify the data have come from homogeneous sources. Sex. Biological difference between two sexes, male and female, and cultural differences between two sexes. Sex is another host characteristic which is often studied in relation to disease using such indices as sex ratio, sex-specific morbidity and mortality rates. It has been found that certain chronic diseases such as diabetes and obesity are more common in women than in men, and diseases such as lung cancer, coronary heart diseases are less frequent in women. Variation in disease frequency between sexes have been described. A. Basis of biological differences between the sex, Y, including sex-linked genetic inheritance, and B. Cultural and behavioral differences between the sexes. For example, smoking, automobile use, alcoholism, due to different roles in social setting. In fact, it is the 4:1 male to female ratio in lung cancer that has helped to identify cigarette smoking as a causal factor. Even larger differences exist. For example, duodenal ulcer and coronary heart disease, they are yet unexplained. Next we have ethnicity. Ethnicity differences in disease occurrence have been noted between population subgroups of different racial and ethnic group. These includes TB, essential hypertension, coronary heart disease, cancer, and anemia. These differences, whether they are related to genetic or environmental factors, have been a stimulus to further studies. Marital status. In countries where studies on mortality in relation to marital status have been conducted, it was found that mortality rates were always lower for married males and females than for the unmarried of the same age and sex. According to demographers and sociologists, the reason for this phenomena may be found in the fact that marriages are selective with respect to the health status of person. For those who are healthy are more likely to get married, with the result that the risk of dying is also less. Besides, married persons are generally more secure and protected and then usually lead a more sober life than those who are unmarried. All these factors are thought to contribute to lower mortality rates among married persons. Marital status can be a risk of factors for some diseases and conditions. The observation that cancers cervix is rare in to the hypothesis regarding marital status and cancer cervix. Further studies led to the suggestion that cervix cancers may be associated with multiple sexual contacts. This is in turn raised the possibility of a possible infectious agents transmitted. Although the viral etiology of cancer cervix is not yet proved, this chain of thinking serves to illustrate how observation can be starting point of an epidemiological inquiry. Occupation. We have it is now well recognized that man's occupation from which he earns his livelihood has an important bearing on his health status. Occupation may alter the habit pattern of employees, for example, sleep, alcohol, smoking, drug addiction, night shifts, etc. It is obviously that persons working in a particular occupation are exposed to particular types of risk. For instance, while workers in coal mines are more likely to suffer from cirrhosis, those in sedentary occupation face the risk of heart diseases. Social class. Higher social class, they have a diabetes, coronary heart disease. Lower social class, they have a nutritional disorders. Social class. Epidemiological studies have shown that the health and disease are not equally distributed in social classes. Individuals in the upper social classes have a longer life expectancy and better health and nutritional status than those in the lower social class. Certain diseases, for example, coronary heart disease, hypertension, diabetes, have shown a high prevalence in upper classes than in the lower classes. Social class differences have also been observed in mental illness and utilization of medical and healthcare services. However, there is one social classification varies from country to country. It has a different meaning for different persons. Therefore, association of diseases with social class vary according to one's concept of social class. Consequently, it is difficult to compare the result of studies in which social class has been used differently by different investigators. Next we have behavior. In the behavior, it's related to cigarette smoking, sedentary life, drug abuse, and overeating. Behavior. Human behavior increasingly looked upon as a risk factor in modern day diseases such as coronary heart diseases, cancer, obesity, and accidents. The behavioral functions which have attracted the greatest attentions are cigarette smoking, sedentary life, overeating, and drug abuse. To this must be added the mass movement of people such as occurs in pilgrimages, which lends themselves to the transmissions of infections, disease such as cholera and diarrheal diseases, insect-borne and sexually transmitted diseases. Stress. Stress affected persons to variables, susceptibility to disease. Stress has shown to affect a variety of variables related to patient response. For example, susceptibility to disease, exacerbation of symptoms, compliance with medical regime, etc. Migration. In Pakistan, disease like malaria are considered to be rural problems. However, because of the movement of people from rural to urban areas, these diseases have created a serious problems in urban areas. Human movement may be classified a short time, long time, or permanent. Number 2, according to age, sex, education, and occupation. Third, internal or external movement. Fourth, urban versus rural migration. has presented challenge to control prevention. Of disease. To sum up, a study of the host factors in relation to disease occurrence is an important dimension of descriptive epidemiology. Variations in the distributions of diseases in age, sex, occupation, and other subgroups of the population can be the starting point of an epidemiological inquiry, leading to formulation of an etiological hypothesis. For further study, knowledge of the frequency of disease in subgroups of the population has also generated the concept of high risk group. We have next slide. This is the measurement of disease. Knowing disease load is important. Measure base mortality, morbidity, disability. Mortality straightforward, morbidity incidence and prevalence. Incidence longitudinal studies, and prevalence is the cross-sectional study. Measurement of disease. It's mandatory to have a clear picture of the amount of disease load in the population. This information should be available in terms of mortality, morbidity, disability, and so on, and should preferably be available for different subgroups of the population. Measurement of mortality is straightforward. Morbidity has two aspects, incidence and prevalence. Incidence can be obtained from longitudinal studies, while prevalence from cross-sectional studies. Descriptive epidemiology may use a cross-section or longitudinal design to obtain estimates of magnitude of health and disease problems in human population. Cross-sectional study. Cross-sectional studies is the simplest form of observational study. It is based on a single examination of a cross-sections of population at one point in time, the result of which can be projected on the whole population, provided the sampling has been done correctively. Cross-sectional study is known as prevalence study. Cross-sectional studies are more useful to chronic than short-lived disease. For example, in a study of hypertension, we can also collect the data during the survey about the age, sex, physical exercise, body weight, salt intake, and other variables of interest. Thus, we can determine how prevention of hypertension is related to certain variables simultaneously measured. Such a study tells us about the distributions of a disease in a population rather than its etiology. The most common reason that epidemiologist examines the interrelationships between a disease or one of its precursors and other variable is to attempt to establish a causal chain and so give light to possible ways of preventing that disease. A point which must be stressed is that the time sequence, which is essential to the concept of causality, cannot be detected from cross-sectional data. However, frequently there is evidence that permits ranking of events to form such a sequence that is, the distribution of pattern may suggest a causal hypothesis, which can be tested by the analytical studies. Although a cross-sectional study provides information about disease prevalence, it provides very little information about the natural history of disease or about the rate of occurrence of new cases, incidence. Prevalence definition is all current cases, number of old cases and number of new cases existing at a given period in a time over a period of time in a given population. There is two types of prevalence, point prevalence and period prevalence. We have incidence. The number of new cases of disease that develops in a population over a period of specific time. Its formula is total number of population people affected with carries over a specified time period divided by total population into 1000. This is a prevalence and incidence. Yellow is the incidence, while blue is the prevalence, old plus new cases. Incidence is only a new cases. This is a bathtub. This is the pink one, indicates the occurrence of death. Comparing with known indices, make comparison, ask questions, and this is the formulation of hypothesis. Okay. We will take all these examples in the longitudinal studies. Here we will discuss the longitudinal studies. Longitudinal studies, there is an increasing emphasis on the value of longitudinal studies in which observations are repeated in the same population over a prolonged period of time by means of follow-up examination. Cross-sectional studies have been linked to a photograph and a longitudinal studies. Longitudinal studies are useful, number one, to study the natural history of disease and its future outcomes. 2. To identify risk factors of disease. 3rd, for finding out incidence rate or rate of occurrence of new cases of disease. In the community, longitudinal studies provide valuable information which the cross-sectional studies may not provide. But longitudinal studies are difficult to organize and more time-consuming than cross-sectional studies. Measurement can also be extended to health states and events. For example, the study of blood pressure levels in a population will reveal the normal values rather than abnormal ones related to disease. Comparison with no indices. The essence of epidemiology is to make comparison and ask questions. By making comparisons between different population and subgroups of the same population, it is possible to arrive at clues to disease etiology. We can also identify or define groups which are at increased risk of certain diseases. 6th, we have formulation of etiological hypothesis. By studying the distribution of disease and utilizing the techniques of descriptive epidemiology, it is often possible to formulate hypotheses relating to disease etiology. A hypothesis is a supposition arrived at a form, observation or reflection. It can be accepted or rejected using the techniques of analytical epidemiology. An epidemiological hypothesis should specify the following: A. The population, the characteristics of the persons to whom the hypothesis applies. B. The specific cause being considered. C. The expected outcome, the disease. D. The dose response relationship, the amount of the cause needed to lead to a stated incidence of the affected. E. The time response relationship, the time period that will elapse between exposure to the cause and observation of the effect. In other words, a hypothesis should be formulated in a manner that it can be tested of cigarette smoking per day, years of exposures, and so on. The success or failure of a research project frequently depends upon the soundness of the hypothesis. Uses of descriptive epidemiology. Descriptive studies, number 1, provide data regarding the magnitude of the disease and types of disease problem in the community in terms of morbidity and mortality rates and ratio. Number 2, provide clues to disease etiology and helps in the formulation of an etiological hypothesis, that is, and a disease is usually recognized in descriptive studies. Thus, if the disease is observed to be more frequent in a particular group than in another, hypotheses are formulated to explain the increased frequency. Third, provide background data for planning, organizing and evaluating preventive and curative services. D, or fourth, they contribute to research by describing variation in disease occurrence by time, place and person.